Hello, everyone. Welcome back to the Road to Pregnancy podcast, where we provide you with pregnancy-related information and local accessible resources here in Rhode Island. I'm one of your co-hosts, Malia.
And I'm your other co-host, Ashley Houlihan. Thank you for joining us on another episode of Road to Pregnancy. As we continue to walk you through the second trimester this season, we wanted to focus today's episode on two symptoms that many pregnant people experience during this stage: headaches and fatigue, including fatigue related to anemia.
Exactly. Even though the second trimester is often called the easier part of pregnancy, many people still experience symptoms that can feel confusing or concerning. So today we'll be talking about why these symptoms happen, when they're considered normal, and when it might be important to reach out to your healthcare provider.
To help us understand this better, we're joined by a very special guest, Dr. Srilakshmi Mitta, who is an assistant professor of obstetrics and gynecology and internal medicine at the Warren Alpert Medical School of Brown University. Dr. Mitta is an internal medicine physician who specializes in the medical care of pregnant patients.
Dr. Mitta, thank you so much for joining us today.
Thank you both, Malia and Ashley, for having me. I feel really honored to be part of your podcast series.
We're so happy to have you. So to start us off, can you tell us a little bit about your role in obstetric medicine and the kinds of patients that you work with?
So I'm an internal medicine doctor, which is an adult medicine doctor, who specializes in obstetric medicine. And obstetric medicine is a unique field that grew out of a need for more medical expertise in the care of pregnant and postpartum patients, especially as more women are entering pregnancy with complex medical conditions. In my role, I care for patients preconception, which is before pregnancy, or when planning to get pregnant, as well as during pregnancy and after delivery. We see a wide range of medical conditions, including chronic diseases like asthma, thyroid disease, hypertension, and diabetes. And we also see common medical complaints like dizziness, shortness of breath, headaches, and palpitations, and more complex cardiac, autoimmune, or hematologic conditions. And mostly we work really closely with the obstetricians to both support the mom and the developing baby to have better outcomes.
Thank you so much for that great explanation. So, Dr. Mitta, many people call the second trimester the easier trimester, and we discussed in episode 1 of this season how it's often referred to as the honeymoon of pregnancy. What is the medical explanation for this?
That is so true. So pregnancy is a time of many hormonal shifts and changes. A specific hormone called HCG, which is made by the placenta very early in pregnancy, and it's kind of the pregnancy hormone that everyone knows about because it's what people are actually testing for when they do a pregnancy test, whether at home or in the hospital. HCG is one of the main hormones that helps support the pregnancy in the early weeks, but higher levels of it also are one of the reasons many people feel nauseous or have morning sickness in the first trimester. But then in the second trimester, people tend to feel nicer or better because nausea and vomiting improve as the HCG levels decline, and their energy levels pick back up as the body adapts to the hormonal changes of pregnancy. Also, the pregnancy usually hasn't become physically difficult yet because the fetus is still relatively small, which helps this trimester feel less burdensome.
That makes a lot of sense. So even though things are getting easier and the HCG is going down, there still are a lot of changes that are happening to the body. So what are some of the most common symptoms that people experience in the second trimester?
So some of the common symptoms and concerns people have during the second trimester of pregnancy include frequent urination, fatigue, heartburn, back pain, and shortness of breath, though these are typically more noticeable towards the middle or the end of the second trimester.
Okay. And that's because of like the hormone changes in the second trimester?
Exactly. You're getting more, that HCG hormone is dropping off, but your estrogen and progesterone levels are going up a lot.
I see. Okay.
I would say one caveat to this, however, is headaches. I get a lot of referrals for headaches in pregnancy, especially in the second trimester.
Okay, so let's talk about headaches first. Why do headaches become more common during pregnancy and especially in the second trimester?
So, headaches are also common in the first trimester. This is often due to dehydration or electrolyte imbalance from the nausea and vomiting people might have, as well as lack of sleep or stress and worry about pregnancy. So, we do tend to see a lot of headaches in the first trimester as well. In addition to this, some patients may even develop headaches in the first trimester from stopping their preventative headache medications or from stopping caffeine and having caffeine withdrawal. Many people stop caffeine altogether, though in most cases, it's safe to have 1 to 2 cups of coffee or tea a day. So, the first trimester can have a lot of causes for headaches and why people might be feeling them, but usually they get better. But there is a small subset of women who also get worsening migraines, worsening headaches around week 13, 14, which is the beginning of the second trimester. And typically these tend to be more migraine type headaches or can be headaches that are hormonally triggered. So people who have had migraines that usually come around their periods, or people who have had something called migraine with aura, which is when they feel visual changes, or they might have funny smells, or get a prodrome of symptoms before they get a headache. That's called an aura. So if people get auras or have migraine with aura, they tend to get worse headaches in the second trimester. So a lot of times they're expecting to feel really good in the second trimester, but they're actually the ones that have the worst headaches, and these can last for 2 months even, and then tend to get better by the third trimester.
And how might someone tell the difference between a typical or expected pregnancy headache and something that might be more concerning?
Yeah, this is such an important question because headaches are really common in pregnancy, but we always want to make sure we're not missing something serious. Most typical pregnancy headaches feel like what patients may have had before, something like a tension or a migraine type headache that comes on gradually, and they might feel similar or familiar to what they had in the past. They might improve with rest, hydration, or simple measures like staying in a dark room or getting a good night's rest. What starts to worry me, though, in headaches is when someone feels that they're different from something that they've had before or different from their baseline, or it's something sudden or severe, or if they use the words, "this is the worst headache of my life." So headaches that just don't go away or keep getting worse are things I would worry about as well. I also pay really close attention to any associated symptoms like vision changes, neurologic changes like numbness, tingling, or change in speech.
And kind of on a similar note, when should someone reach out to their provider or seek care for a headache during pregnancy?
So I usually tell patients it's always okay to check in if something feels off, but definitely seek care if your headache is severe, persistent, not improving with usual measures, or associated with any of those concerning symptoms I just spoke about. And really, if it's just not your usual headache and something is not right, call your provider. We'd much rather know about it than you suffer at home alone.
Yeah, that's great advice. So what treatments are generally safe for headaches during pregnancy? And are there any medications that people should avoid when they're pregnant?
So for treatment, we try to start with the basics: hydration, good sleep, stress reduction, and sometimes a little caffeine can actually help. Sometimes if people stop drinking coffee, I just tell them to have another cup every day, which makes them quite happy.
Yeah.
But in addition to that, acetaminophen or Tylenol is generally considered safe and is usually our first-line medication. But the one caveat is, if people are going to take it, they need to take a sufficient dose to actually treat the headache. Sometimes people just take one tablet or like a baby dose, and that's not going to do much. Typically, you need to take at least 1 gram or 1,000 milligrams. And if you take less, you may not get the intended effect, which is getting rid of the headache, but you're still exposing yourself and the fetus to a medication without much benefit.
Great. And I also just wanted to mention here, too, that we have an episode on Tylenol and pregnancy. So if you're interested in learning more about that, we recommend listening to our Tylenol episode in season 1.
I love that. I think that the whole thing about whether to treat Tylenol and the side effects are like something that are going to come up in a lot of visits. So I'll have to listen to that episode. But other things and other options that we have to treat headaches in pregnancy really are dependent on the situation. But we really try to individualize that based on the root cause of the headache. Many times we also recommend preventive strategies or medications. Things like magnesium, beta blockers, or a medication called amitriptyline are often our first-line agents for medications to help prevent migraines or headaches in pregnancy. And then in terms of things to avoid, we're more cautious with medications like NSAIDs, which are like a group of medications like Advil or Motrin or naproxen, especially in later pregnancy, but we tend to just avoid them altogether in pregnancy. We also avoid many of the preventative or migraine-specific medications like Topamax or some of the newer medications that are on the market because we just don't have the data to support its safety in pregnancy. And one big thing, it's always important to check with your provider before taking anything new. And this really highlights the importance of preconception care. We really need people to come in earlier before they're pregnant to actually make sure that any of the medications they need are safe and can be continued during pregnancy. The key is that we do have safe options, but we want to be thoughtful and tailor it what is best for the patient.
That's a great point and is something that we've talked a lot about on the podcast, the importance of preconception care. And even if you think you wouldn't benefit from it, you probably can for reasons like this. And if somebody, say, like, is a little bit anxious about taking medication during pregnancy or just prefers more of a non-medical management, are there like lifestyle changes that someone can make to help prevent or reduce headaches?
Yes, actually, honestly, lifestyle measures are a big part of headache prevention in pregnancy and make a real difference. Staying well hydrated is key, especially since even mild dehydration can trigger headaches. Getting consistent, good quality sleep also matters. Both too little sleep and disrupted sleep can worsen headaches. Regular meals are also important because low blood sugar can be a trigger for headaches. And like I said before, caffeine can actually be helpful in small amounts. Patients don't need to cut it out completely and have 1 cup of coffee or tea a day, which can really help to prevent or treat headaches, especially if someone is used to it on a regular basis. And then stress management, whether that's light exercise, stretching, or just building in time to rest, can go a long way. We also often talk about trying other supportive modalities like massage, physical therapy, or even acupuncture, especially for patients who have more tension-type headaches or muscular triggers. So a lot of this really is about consistency with daily habits and using a combination of approaches, which can be surprisingly effective in reducing headache frequency and severity.
Great. Okay. So as you said before, another really common symptom in pregnancy is fatigue. Why do so many people feel so tired, even in the second trimester?
So the second trimester, which spans from about week 13 of pregnancy until around weeks 27 to 28, it's a long period of time, so a lot can happen. So even though the second trimester is often described as having more energy, fatigue is still incredibly common in pregnancy, and a lot of patients still feel pretty tired. There are a few reasons for that. Pregnancy is a huge physiologic and metabolic demand on the body. This person is creating life. Their body is changing rapidly. It's quite amazing. And we don't realize what pressure it is on the body at a cellular level. So your body has to build a placenta, support a growing fetus, and has a lot of increasing blood volume. All of this requires energy and more nutrients. Sleep can also be disrupted during this time, even early on in pregnancy. So even in the second trimester, it's very normal to not quite feel like yourself and feel more tired.
And how can someone tell the difference between what's expected to be normal for pregnancy and fatigue caused by something like anemia?
That's a great question because there's definitely overlap. Normal pregnancy fatigue tends to be more general, feeling tired, needing more rest, maybe getting fatigued more easily with your usual daily activities. But when I start to think about something like anemia, I look for additional symptoms, things like shortness of breath that's out of proportion to activity, feeling lightheaded, palpitations, or looking pale. It's also important if the fatigue feels more severe than expected or is progressively worsening. But honestly, it can be hard to tell just based on symptoms alone, which is why we rely on routine screening labs during pregnancy to help us pick up anemia early.
So why are pregnant patients more at risk for developing anemia?
That's also a great question and one of my favorites. To start, I wanted to define that anemia is when your hemoglobin level in the blood is lower than normal, meaning that there are fewer red blood cells available to carry oxygen throughout your body. Pregnant patients are more at risk for anemia, mainly because of this increased blood volume that all pregnant patients are going to have happen in their pregnancy. So after about 20 weeks of pregnancy, around the halfway point of pregnancy, iron requirements increase significantly because you're supporting both your own body and the developing fetus and placenta. So if someone doesn't have enough iron stores going into pregnancy or isn't able to keep up with those increased demands of pregnancy due to either low iron intake in their diet or that they had nausea, vomiting, and really couldn't eat well, they can develop iron deficiency anemia during pregnancy as well. In general, though, iron deficiency is the most common cause of anemia in later pregnancy. But I do want to point out that a big part of what I do as an internal medicine doctor is to think about all possible causes of anemia. This is especially true if it's early in pregnancy or more severe than expected for a regular pregnancy. So anemia in the first trimester or a large drop in the hemoglobin should prompt us to think about other causes beyond just iron deficiency.
And what are some other causes beyond iron deficiency anemia that you might see?
So sometimes when I see anemia in the first trimester, which is not when you expect the pregnancy to have a lot of demands, then you start thinking, okay, this must have been something that pre-existed the pregnancy. So things that are common are problems with the hemoglobin, like sickle cell or something called thalassemia, which are common genetic causes for a low hemoglobin. Other causes might be that someone might just have really heavy periods and they bled a lot and didn't eat enough iron-rich foods. So then they weren't able to keep up with their demands when they weren't pregnant and then entered pregnancy with low iron. And then other nutrients are really important for anemia, like folic acid and B12. So these vitamins are really important to check for as well.
And how do you actually diagnose or screen for these different types of anemia during pregnancy?
So usually in pregnancy, we don't screen for all of these because iron deficiency is the most common cause of anemia in pregnancy. But anemia is a very common thing in pregnancy and is routinely screened for during prenatal care with simple blood work. Most patients will have a complete blood count or a CBC early in pregnancy at one of their first prenatal visits to establish a baseline of where their hemoglobin is. And then it's typically repeated again in the second or early third trimester. So usually between like 26 to 28 weeks. If there are any concerns or symptoms, we may check additional labs like ferritin, which tells us about iron stores, or other iron studies to better understand the cause and to guide treatment. So it's something that is actively screened for throughout pregnancy and something routinely done by all obstetric providers.
Okay. And if someone is diagnosed with iron deficiency anemia, what are the most effective ways to treat it? Are there foods or nutrition tips that can help support healthy iron levels during pregnancy? Or does somebody have to take supplements every day for the rest of the pregnancy? What does that look like?
So if someone is diagnosed with iron deficiency anemia, the mainstay of treatment is iron replacement. This is usually done with oral iron tablets, and we often talk about how to take it in a way that improves absorption. Like take it with some vitamin C, avoid taking it with calcium-rich foods like dairy, or even taking it every other day can actually increase the absorption rather than taking it every day.
Okay.
So it's okay if you forget your iron tablets sometimes.
Good to know.
But oral iron works well if it's taken properly, but so many people have difficulty tolerating it because they cause stomach upset and constipation. And pregnant people already have constipation and reflux, so sometimes taking an iron tablet can be really difficult. So for some patients, especially if they can't tolerate the oral iron, or if the anemia is more severe, Or if they have significant symptoms like shortness of breath, dizziness, or palpitations, we may even recommend using IV iron or getting iron through an IV where they have to come to the hospital and actually get it infused. This can be very effective and works more rapidly than the oral iron. And I think you had also asked about nutrition.
Yeah.
The key to anemia, especially in a young person, is nutrition. And lifelong nutrition. So having a really good diet with iron-rich foods like dark leafy greens, like spinach, kale, broccoli, or red meat, liver, beans, lentils, and even things like beets can help support healthy iron levels. That said, this really needs to be part of someone's habits even before they're pregnant or in early pregnancy, because it's very hard to correct iron levels once pregnant with diet alone. So it's really a combination of medical treatment with supplementation and supportive dietary changes and counseling.
And that kind of goes back to one of your earlier points about why preconception care is so important, because if you are anemic before pregnancy, we can catch it, we can correct it, and we can modify your diet so that you're going into your pregnancy in better health.
And even bringing up these things during, your first initial prenatal visits, right? Saying like, I'm vegan, or I don't eat a lot of red meat, or I don't eat a lot of greens, kind of establishing that with your provider so that you can work toward maybe taking iron supplements earlier on to help you not have those anemic experiences later on.
Exactly.
And so to kind of summarize our big take-home points from these two different topics, what are symptoms related to headaches or fatigue that pregnant patients should not ignore?
Yeah, so to wrap up, for headaches, anything that is severe, persistent, not responding to regular medication, or feels different from your usual headaches, or associated with vision changes, neurologic symptoms, really should prompt you to come see one of your providers and get evaluated. And then for fatigue, if it feels out of proportion to what you would expect, is worsening, or is associated with symptoms like shortness of breath, dizziness, or palpitations, or passing out or feeling faint, that's something to check in about. But bottom line, if something just doesn't feel right, it's always okay to reach out. Patients know their bodies the best, and they are the expert in that. So lean into those instincts. They're important for us to know about because you know yourself best.
Yeah, thank you for highlighting that. And then for pregnant patients here in Rhode Island who might be experiencing severe fatigue or anemia, where can they go for support?
I love Rhode Island because we have a lot of supports for pregnant people. So for pregnant patients here in Rhode Island or anywhere really, the first step is always to reach out to your OB provider. They know your pregnancy best and can help guide next steps. If symptoms are more severe or you're concerned, going to the emergency department is always appropriate, especially if you're having things like significant shortness of breath, chest pain, or severe headaches. Sometimes even the ER, they might be a little bit wary about treating a pregnant patient. So getting your OB provider involved in your care or calling them from the ER might even be something you'd want the ER provider to do, or you can do yourself if you want. Advocating for yourself will be really important because sometimes being pregnant, you might get underdiagnosed for things. So really reach out to your OB provider. They're the ones who will do a lot of that advocating.
Do you recommend going to the Women and Infants ER?
Yes. The Women and Infants ER are special doctors there, midwives, nurses, and they all feel comfortable with medical problems in pregnancy. So definitely go to the Women and Infants ER. If you aren't taken there or you took an ambulance to the ER, you can ask to be transferred.
Okay, good to know.
But here in Rhode Island, we also have specialized services, including my team of obstetric medicine specialists, where we care for pregnant patients with medical concerns. Almost every obstetric provider in Rhode Island knows about us and can refer to us. So there are definitely resources available. And the key is not to wait if something feels concerning.
Now, to close out the episode, for someone currently in their second trimester, what advice would you give them for staying healthy and feeling their best?
I would say focus on the basics because they really do go a long way. Stay well hydrated, and that's with 3 liters or 96 ounces of water a day. Try to get consistent sleep, eat regular, healthy, and balanced meals, and don't ignore how you're feeling. Keep up with your prenatal care, ask your provider questions, not Google or AI or ChatGPT, and advocate for yourself if something feels off. Lastly, I'd say give yourself some grace. Your body is doing a lot during this time.
Yeah, thank you so much. That's such wonderful advice. Thank you, Dr. Mitta, for joining us today and for sharing your expertise on headaches, fatigue, and anemia during the second trimester and during pregnancy in general. We really appreciate you helping us break down these common symptoms and explaining when they're normal and when someone might want to reach out to their healthcare provider.
Well, thank you both so much for having me. This was really fun. And I'm always happy to talk about this because these are such common symptoms that can feel really overwhelming to someone when they're pregnant. I also really love being able to advocate for improved medical care for pregnant patients and to help educate women about their bodies and their health. It's such an important part of what we do. Thanks again for having me.
Now, before we wrap up, we also wanted to highlight a few more resources here in Rhode Island for pregnant patients who may be experiencing symptoms like fatigue or anemia. Programs like the Rhode Island WIC program can help provide nutritional support, including access to iron-rich foods and prenatal nutrition counseling. You can also find pregnancy and health resources through the Rhode Island Department of Health website. Both of these will be linked in the show notes.
Thank you so much to everyone listening to the Road to Pregnancy podcast. We hope this episode helped answer some questions and gave you helpful information as you navigate your pregnancy journey.
If you enjoyed this episode, be sure to follow the podcast and share it with someone who might find it helpful. You can also follow us on Instagram for more pregnancy-related information and local resources here in Rhode Island. Thank you, and we will
see you next time.